most common lesion responsible for drug-resistant epilepsy in children. It is also one of the most challenging lesions to detect as the MRI features are frequently subtle. So why is it important to detect focal cortical dysplasia? Patients with MRI-negative epilepsy have poorer surgical outcome compared to those with a lesion seen on MRI. By improving the detection of focal cortical dysplasia, you increase the likelihood of seizure-free surgical outcome and can change pre-surgical planning by changing placement of intracranial EEG electrodes. What are the MRI features of focal cortical dysplasia? These include thickening of the cortex, blurring of the gray-white matter junction, high T2 or flash signal in the cortex and subcortical white matter, and tapering of the abnormal signal towards the ventricle. The last feature is phallic characteristic of FCD type 2B. The other features of focal cortical dysplasia include high T1 signal in the cortex and abnormal sulcation and gyration pattern. In the International League Against Epilepsy classification of focal cortical dysplasia, there are 3 subtypes of focal cortical dysplasia. Type 1 and type 2 lesions are isolated lesions, and type 3 lesion includes focal cortical dysplasia associated with an additional lesion, such as hippocampal sclerosis, epilepsy-associated tumors, vascular malformations, and other lesions. Type 1 lesion has abnormal radial or tangential cortical lamination. Type 2 lesion has cortical dyslamination and dysmorphic neurons. Type 2A does not have balloon cells, and type 2B has balloon cells. So let's have a look at some examples of focal cortical dysplasia, starting with FCD type 1. In this example, in a patient with left temporal lobe epilepsy, there is mild increase abnormal signal on flare and proton density in the left anterior temporal lobe. In the next example of FCD type 1, but in an infant, there is abnormal sulcation and gyration pattern in the left perisylvian region and also left frontal cortex. In addition, there is thickening of the cortex and abnormal signal in the white matter, consisting of lower T2 and higher T1 signal. The changes in the white matter is thought to be due to accelerated myelin maturation from recurrent seizures. Moving on to FCD type 2B, also known as Taylor's focal cortical dysplasia or focal cortical dysplasia with balloon cells. In this example, there is abnormal signal in the cortex with tapering of the abnormal signal towards the ventricle. Please note that the abnormal signal must have a broad base that involves the cortex and tapers downwards towards the deep white matter. If it's simply a linear hyperintensity that starts at the gray white matter junction into the deep white matter, it's more likely to be perivascular space. There is a subtype of focal cortical dysplasia known as bottom of sulcus dysplasia or BOSD. This could either be FCD type 2A or FCD type 2B. Bottom of sulcus dysplasia are generally smaller compared to focal cortical dysplasia that involves the gyrus or the surface of the brain. Because they're small, they're frequently overlooked on MRI. In fact, in our series, almost 50% of the cases were overlooked by the reporting neuroradiologists. It is important to identify this lesion even though they are subtle, because the vast majority of these cases have really good surgical outcome, somewhere in the order of 80 to 90% seizure freedom rate. Contrast this with the other subtypes of focal cortical dysplasia, where the seizure freedom rate varies from 50 to 70%. So on this slide, I have shown you 5 different examples of bottom of sulcus dysplasia. Out of these 5 cases, 4 of these were initially reported as normal, and they were identified only on second review of the imaging. As you can see, the lesions are really subtle and therefore challenging to identify. Moving on to FCD type 3. In this particular example, there is a low-grade tumor in the right amygdala. If you look carefully at the superior temporal gyrus, there is mild increased T2 signal in the right superior temporal gyrus white matter. Histology shows FCD type 1 in the superior temporal gyrus. Hence, this is FCD type 3. Please note that the MRI appearance of focal cortical dysplasia may change with time due to increased myelination with brain maturation or due to seizure-related changes. The ILAE has indicated that there is an unfavorable time window, typically between the age of 6 months to 2 years, at which time a lesion such as focal cortical dysplasia can be masked because of increasing but yet incomplete myelination. They have recommended repeat imaging every 3 to 6 months and if tolerated after the age of 2 years. So in my personal opinion, I think this is rather excessive. I would normally recommend that our neurologists repeat the imaging after the age of 4 years when myelin is more mature on flare and proton density if tolerated. However, if the patient has severe intractable epilepsy requiring more urgent pre-surgical evaluation, then I would recommend repeat imaging sooner rather than later. In this example of left temporal lobe epilepsy, initial imaging at 11 months of age was normal. With brain maturation and with seizure-related changes, there is increased T2 signal in the left anterior temporal white matter as well as in the left amygdala on repeat imaging at 5 years of age. In this particular example of right perirolandic focal cortical dysplasia, the lesion is rarely obvious at 8 weeks of age. However, with brain maturation, the lesion becomes less conspicuous at 5 months of age. This phenomenon has been termed as the disappearing focal cortical dysplasia. The sensitivity of lesion detection depends on several factors such as pathologic substrate, MR imaging techniques, and the interpreting physician. You can optimize the MRI technique to improve the contrast and gray-white matter distinction by doing multiple sequences in multiple planes and improving the resolution of the scan. You can increase your chances of identifying subtle lesion. We have previously developed a guideline on epilepsy surgery evaluation. The guideline was developed based on review of the literature, review of existing guidelines, and also based on expert opinion. We've included a variety of procedures such as MRI, PET-SPECT, fMRI, and MEG, and also we included reporting guidelines. For the MRI component of the guideline, we've divided this into 3 different age categories, those for adults, for children, and for neonates and infants. For neonates and infants, we recommend doing T1 weighted imaging and high-resolution T2 weighted imaging. Flare and proton density are not recommended because of myelin immaturity. You can also do higher resolution imaging by using thinner slices and higher matrix and doing the scan on 3T. If available, 7T is recommended. In our institution, we would routinely repeat the MRI using higher resolution techniques through the area of concern if the initial MRI using epilepsy protocol done on 3T did not reveal a lesion. So this is one such example whereby the repeat imaging using higher resolution technique through the area of concern demonstrates subtle increased signal in the subcortical white matter of the left perirolandic region. Histology shows FCD type 2. This is another example whereby the repeat imaging using higher resolution techniques demonstrate mild increased T1 signal in the cortex, blurring of the gray-white matter junction, and slightly atypical sulcation. Histology also shows FCD type 2. In the guideline that we publish, we recommend that the scans should be interpreted in the context of clinical semiology and video EEG. In the guideline, we also stipulated that the neuroradiologists with interest in epilepsy should review the MRI of cases that were considered to be normal or have questionable subtle changes when all clinical video EEG and functional imaging data such as PET, SPECT, and MEG are available. The person reporting the scan should be familiar with normal sulcation and gyration pattern. When the sulcation and gyration pattern is very abnormal, such as in this case of right hemispheric polymicrogyria, it is easy to identify. However, when the sulcation and gyration pattern is mildly abnormal, it can be difficult to distinguish from normal variation. So on this slide, I've shown you 6 different images. 5 of these belong to normal healthy control. And only 1 image belongs to a patient with focal intractable epilepsy. So guess which image belongs to the patient with epilepsy? It is the middle image on the bottom row. There are tips and tricks that you can use when reviewing the images in order to improve the conspicuity of the lesion. So for instance, this is the regular window that one would normally review the T1 with the imaging on. By changing the window such that the gray matter appears darker, you increase the conspicuity of mild increased T1 signal in the cortex. Similarly, this is the regular window that one would normally review the T2 flare and proton density images on. By changing the window such that the white matter appears darker, you increase the conspicuity of mild increased signal in the subcortical white matter. It is easy to overcall a lesion because of partial volume effect. In order to minimize false positive, I would normally recommend that the lesion should be seen on at least 2 slices and on at least 2 sequences or 2 planes. So these are tips and tricks that you can use to improve detection of focal cortical dysplasia in your daily practice. We are currently working on using machine learning to improve detection of focal cortical dysplasia using convolutional neural network and more recently, fully convolutional network to detect focal cortical dysplasia. So moving on to mimics of focal cortical dysplasia. There are 2 entities that can mimic focal cortical dysplasia on imaging. These are astrocytic inclusion, also known as filaminopathy, and oligodendroglial-like cells. Several terms have been linked to oligodendroglial-like cells, including oligodendrocytosis, oligodendroglial hyperplasia, and mild malformations of cortical development with oligodendroglial hyperplasia, also known as MOGHI. With astrocytic inclusion, the main feature that will help you distinguish this entity from focal cortical dysplasia is the clinical presentation. Patients with astrocytic inclusion are more likely to present with periodic spasms compared to focal cortical dysplasia. With oligodendrocytosis, the imaging features are very similar to focal cortical dysplasia type 1. The surgical outcome is also very similar to focal cortical dysplasia type 1. In fact, some patients may have dual pathology of oligodendrocytosis and focal cortical dysplasia. So let's move on to differential diagnosis of focal cortical dysplasia. So we'll start off with the first differential diagnosis. So this lesion located in the left basotemporal lobe demonstrates high T2 and flash signal. However, if you look carefully, there is a small focus of very low flash signal and very low T1 signal. So this is low-grade tumor. There are several features that you can use to distinguish low-grade tumor from focal cortical dysplasia. Low-grade tumor are more likely to have more mass effect, may show enhancement, may show calcification, and the white matter may show an area of very low T1 or very low flash signal secondary to cystic changes. In my experience, the last feature is the most helpful feature to distinguish between low-grade tumor from focal cortical dysplasia. In focal cortical dysplasia, the white matter is iso-intense or minimally lower T1 signal or higher flash signal compared to the adjacent white matter. Let's move on to the next differential diagnosis. So this lesion in the left frontal lobe shows lower T2 and lower flash signal in the cortex, and the subcortical white matter demonstrates higher T2 signal. The lower T2 signal and lower flash signal is thought to be due to the presence of stipple calcification in the cortex. So this is meningoangiomatosis. Meningoangiomatosis is a benign vascular proliferation of the leptomeninges and cortex. Calcification may be fine and stippled and confined to the cortex, or it may involve cortex and subcortical white matter and appears more clumped or cause calcification. The lesion may or may not show enhancement. Moving on to the next differential diagnosis. So this lesion shows high flare signal in the subcortical white matter. On T1 weighted imaging, there is a focal area of thinning of the cortex. So this is Rasmussen encephalitis. With focal cortical dysplasia, it usually does not produce this degree of cortical thinning. Rasmussen encephalitis is an autoimmune encephalitis. Early on in the disease, the imaging may be entirely normal or may show mild swelling of the cortex associated with high flare signal in the cortex and subcortical white matter. With disease progression, there is progressive atrophy and progressive abnormal signal in the white matter and cortex. Moving on to the next differential diagnosis. This is a 9-month-old with new onset focal left-sided seizures. Diffusion weighted imaging demonstrates diffusion restriction in the pre and post central gyrus, and there is increased T2 signal in the subcortical white matter of the right post central gyrus. So this is POLG1 mutation. With focal cortical dysplasia, even when the patient is in status epilepticus, I have not seen diffusion restriction in the lesion. So in this particular case, a month after presentation, the patient develops new abnormal signal in the right basal ganglia and also diffusion restriction. So with this entity, there is missense mutation in the POLG1 that encodes mitochondrial DNA polymerase gamma. The patient may present with severe epilepsy, epileptic encephalopathy, and encephalopatopathy. Please note that sodium valproic acid is contraindicated in this condition, and death has been reported in those exposed to sodium valproic acid. Hence, it is important to be aware of this condition so that the clinician knows that they should not give sodium valproic acid. Moving on to the next differential diagnosis. So this is a patient who presents with new onset focal seizures, right arm rigidity, and visual hallucination. MRI demonstrates a focal area of flare hyperintensity in the right parietal cortex. Given the clinical presentation, this is likely to be autoimmune encephalitis. The most common form of autoimmune encephalitis is anti-NMDA encephalitis. It occurs much more commonly in women and may be associated with tumors. In addition to seizures, the patient may present with behavior changes and bizarre movements. So to summarize, focal cortical dysplasia is one of the most challenging lesions to detect on imaging. You can improve lesion detection by optimizing the MRI, reviewing the MRI with knowledge of the location of the epileptogenic zone, and with meticulous review of the imaging. Sometimes it may be necessary to review the imaging more than once in order to pick up subtle lesion. Last but not least, consider the differential diagnosis for focal cortical dysplasia. So in the last minute or so, I will leave you with this challenging case to find the subtle focal cortical dysplasia type 2B. Which quadrant do you think the lesion is located at? I will give you the answer during Q&A session. So to give you an idea of how challenging this case is, if you look at the top right-hand image, this is me when after reviewing the images for 2 hours and I still could not find the lesion. However, I persisted and an hour later, I did find the lesion.